Thank you for inviting me to speak at this AIDSImpact 2021 on vaccines and vulnerabilities. I'll be discussing ethics and equity of vaccine and treatment, comparing and contrasting HIV and the COVID-19 pandemic. Now, a week or so ago, we commemorated the report of the 5 gay men in the MMWR that kind of signifies the beginning of the HIV pandemic. And since those cases and that report 40 years ago, we know that we've had 75.7 million infections and 32.7 million deaths. Just to recap the HIV AIDS timeline since that first reported cases, as many of you will recall, it took approximately 3 to 4 years before the virus that was causing this terrible disease amongst gay men and later in other vulnerable communities, was isolated by François Baris-Nussi and team, and it then took another year and a half before a test for this virus was developed. In contrast, as we all know, the COVID-19 research and development of the testing, diagnosis was very, very rapid. As soon as the full genome sequence was shared with the world, testing, including in my own country, Malaysia, was able to be carried out very quickly. And the reason why I'm kind of belaboring this a little is in terms of contrasting the speed by which the HIV versus the COVID-19 knowledge and data that led to the development of diagnostics, therapeutics, and vaccine have, of course, we live in a different era. This was 40 years ago, but nonetheless, I think there are interesting things that we can compare and contrast, and ultimately, move forward in terms of the pandemic. We then had, approximately 15 years or so before effective treatment was developed. So combination antiretroviral therapy really became available in 1996. And this is where I think the question of equity was first acknowledged, because in many people living in wealthier countries, they were able to make use of this effective treatment, and were able to, in wealthier countries, we were able to see a drop in the number of deaths, but not so in countries that were not able to access this effective treatment. Just recalling my own practice here in Malaysia in 1998, when the drugs first became available in Malaysia, it was only my wealthy patients who could afford to pay the $700 a month for heart, as they were known at the time, and yet those who were not able to fork out that sum of money were left literally to die. And so it took many, many years, and many million numbers of people who died. In 1999, the toll reached 14 million deaths and 33 million people living with HIV, 3 years after the discovery of highly effective treatment. And then it took another 6 years before the world kind of galvanized through the 3x5 initiative of the World Bank and WHO and others that committed to treating more people with this highly effective antiretroviral therapy. And then, of course, following that, we had the creation of the Global Fund and PEPFAR that have saved many millions of lives subsequently. Nonetheless, as I tried to recall, it took many years. Yes, the science is not where we are today, from the discovery of the virus to diagnostics and therapeutics. But even at the point of time when effective treatment was known, it was a full 9 years before the world really galvanized. And unfortunately, I think we are living through a similar situation currently with the COVID-19 vaccine. This is another graph that tries to illustrate how more deaths occurred in countries like South Africa, Malawi, Zimbabwe, Mozambique, following the discovery of heart in 1995, compared to before the time of discovery, and yet in the United States, following, post 1995, the number of deaths flattened, as you can see from this curve here. Although scale-up of antiretroviral therapy has happened throughout the world, and we are now seeing remarkable decline in the number of deaths in sub-Saharan Africa and many parts of the world. Nonetheless, the inequality and the inequity that's been one of the major features of the HIV pandemic continues. And despite the great advances in HIV treatment as well as prevention, and you can see this diagram of all the toolkits that we have with us, what is preventing us from reaching our goal of ending AIDS by 2030, one of the main drivers is, of course, inequity and inequality. I'm just going to, in the next few slides, just highlight some of the key areas where inequity is responsible for, having more infections and allowing us not to reach our goal of ending AIDS. We've not been able to reach the targets that we promised of reaching in 2019. Instead of just having 500,000 new infections, which was the promise that we made, we actually had 3 times the number of new infections at 1.7 million. And this is before the COVID-19 pandemic disrupted many of the treatment and prevention programs around the world. Moving on to the Asia and the Pacific, recent data has shown that key populations and their partners account for an estimated 98% of new HIV infections in my region. And you can see from this graph here from UNAIDS, gay men and other men who have sex with men make up 44% of that, followed by people who inject drugs, sex workers, and transgender people and clients of sex workers. So once again, the inequities seen amongst these highly stigmatized and marginalized population in Asia and the Pacific provides all kinds of barriers and challenges for them to access care, whether it's preventative care or treatment for HIV. And you can see here, not surprisingly, this translates to poor testing and treatment cascade outcome and performance in Asia and the Pacific in comparison to other countries and other continents. Of course, inequities alone doesn't explain this, but nonetheless, in a region where a large proportion of those infected are amongst the marginalized population, we face not just programs, but obviously individuals face many barriers to accessing prevention and treatment programs. So it is not surprising, before I move on to COVID, it's not surprising that we have failed to reach our targets. The concern is, of course, COVID-19 is making us reach those targets even more, but making us, giving us difficulties to reach those targets in even more. Now, if we contrast that of COVID pandemic, of course, the number of people who've been infected in such a short time, in the 18 months since the disease was recognized, is several folds more than the HIV pandemic, simply because of the ease of transmissibility of the virus, and also because of the large number of asymptomatic people who go undetected and spread the virus to others, and the large number of deaths that have occurred in the last 18 months. And just to go through the timelines very quickly and to contrast it to that of the HIV that I outlined earlier, of course, by January 13th, 2 weeks after, or just 2 days after China reported its first death, and 2 weeks after cases were being reported, the Chinese scientists submitted the gene sequencing data, and shortly after that, many countries, as I mentioned, including my own, were able to design primers for the PCR that led to diagnostic tests being developed and utilized to identify cases all over the world. And it was 2 weeks later that the WHO declared a global health emergency. And as we say, the rest is history, with you know, the development of the vaccines in less than 12 months, which many have described as being a modern miracle. There are, at last count, 93 vaccines in clinical trials on humans, and 31 have reached the final stages of testing, and approximately 8 or so vaccines that are now widely used around the world. This is from June 15, from the Bloomberg COVID-19 tracker, where it was reported that more than 2.39 billion shots have been given in the US alone, that made up 311 million doses that have been administered. This is a map from the same publication of where these vaccines have been deployed. So the dark green color is for countries and areas where more than 30% of the population has been covered. And as you can see, it's dominated by North America, Western Europe, China, and some countries in Southern America, and also the Middle East. But in other parts of the world, notably in sub-Saharan Africa, you have a very, very pale green color, where less than 1% of the population has been vaccinated. The stark inequity and difference, as depicted in this map, is, I think, for all to see. In my own country, we are doing our very best to roll out the vaccine in the face of a rather nasty surge that we're experiencing at the moment. And even with the best of efforts, we've only reached about 10% of the population. So this hotly discussed issue of this uneven access to vaccines, where the wealthiest 27 countries have 26.3% of the vaccinations, but they only make up 10.4% of the world's population. And in some of the most populous countries, vaccination has very much lagged behind. And of course, for the entire African continent, I think less than 2% of individuals have been vaccinated. Global vaccine inequality and uneven access is not only at the global level, where the figures that I shared shows how uneven it is between wealthy countries and poorer countries, but the uneven access to vaccine or unequal distribution of vaccines occur at the national level as well. And one group of individuals who are usually not seen as at the top of the list of those who should be vaccinated, even though they make up a very, very high risk, or they make up very high risk individuals, are those who are incarcerated. In most national programs, you will see, rightly so, the list of those who are given priorities would include healthcare, firstly, healthcare workers and other frontliners, the elderly, those who have comorbidities such as diabetes, heart disease, obesity, etc. It's very rare to see incarcerated persons to be on that same list, even though we know that up till as many as 500,000 individuals who are incarcerated have been infected with COVID-19 globally. So unequal or uneven access occur at the national level, even in countries where vaccine rollout is occurring. As mentioned before, prison systems, and globally there are more than 11 million prisoners who have been disproportionately affected by COVID-19, and estimated 527,000 prisoners have become infected with the virus in 122 countries, with 3,800 fatalities in 47 countries. But rarely are they included in at least the first or second phases of vaccine rollout. Another group that have suffered from the unequal distribution of vaccine are migrants and refugees in my own country and in several countries in Southeast Asia who are dependent on migrant workers. We've seen large outbreaks of COVID-19 in Malaysia, clusters arising from factories that hire migrant workers continue to be the main, if not the major source of ongoing transmission. Singapore has had its fair share of outbreaks due to amongst those dwelling in dormitories and factories workers, and Thailand has also experienced the same kinds of outbreak. Not yet in most countries, once again, access to vaccine for these migrant workers is usually not prioritized. I believe Singapore has, and Thailand has also included. In Malaysia, it's included, but it currently is not seen as a priority over those of the elderly and with comorbidities. Many have tried to address this, the injustice. This is probably a soft term to describe what's going on around the world at the moment with such unequal distribution of vaccine in rich and poor countries, as we try to recall after 40 years of HIV/AIDS, we hope that we don't make the same mistakes of allowing millions and millions of people to die months, years after highly active antiretroviral therapy were designed before the World Act. I think we all must look back on that blot in the history of medicine and not repeat it with that of our response to the COVID-19 pandemic. This is an adaptation from a publication in New England looking at how the COVID-19 vaccination can be scaled up using lessons from the HIV pandemic, looking at the creation of the Global Fund, of course, and PEPFAR. Of course, we now have COVAX, but even COVAX, I believe, is struggling to get adequate supply. Practically, there are many things that can be learned from the vaccine rollout, not the vaccine rollout, but the ART rollout in HIV that can be applied and used in our vaccine rollout for COVID-19. I just want to end this discussion on the inequalities and inequities in relation to COVID-19 and the HIV pandemics and make a plea to all of us here listening that I think those of us who've worked in the HIV field all these years perhaps need to voice out a lot stronger in terms of not repeating the tragedies that we saw with the HIV pandemic. And I just want to read this excerpt from Zainab Tufekci, who writes beautifully in The Atlantic and the New York Times on this subject in a recent op-ed that she published in the New York Times. So we all acknowledge that vaccine production is hard, and merely waiving the patents as has been decided is, she says, like the thoughts and prayers politicians express after tragedies after which they do little or nothing, and the tragedy continues unabated. Officials from all nations that produce vaccines need to gather for an emergency meeting immediately to decide how to commandeer whatever excess capacity they have to produce more through whatever means necessary. Because of the threat of increased transmissibility, and since the evidence at hand indicates that all of the vaccines, even the Chinese and Russian versions, appear to be highly effective against severe disease or worse, the focus should be on manufacturing and distributing the highest number of doses possible as fast as possible. So, colleagues, I make a plea to all of us here to make our voices heard, to get our political leaders to move to get as many vaccines as possible out there in all countries and all regions of the world. Thank you very much.